Rahmanir-Rahim. Auzubillahi minash shaitanir-rajim. I start the CME with the name of Allah, who is most beneficial, merciful, and very kind. My CME update by Mother and Child Survival Group of Pakistan. Me, Dr.Tariq Masood Khan, Family Emergency Ops Gynae Specialist, presently working as a district gynecologist in a district gynae setup. The topic of CMA is PCO, Polycystic Ovarian disorder, the most common endocrine disorder in women. It's about 80% cause of women subfertility, and also 6 to 10% presence in childbearing age, and about 20 to 30% present in ultrasound. How to diagnose? There is a Rotterdam criteria, which is basically absent ovulation, irregular or absent ovulation, and second is the signs of hyperandrogenism, which are basically weight gain, hirsutism, weight hirsutism, alopecia, and acne. And there are more than 12 antral follicles in one ovary, and ovarian volume greater than 10 ml. You have to exclude 2 at least out of these criteria. Now, the basic etiology is there is signs of, as we have told, hyperandrogenism. There is increased production of LH. LH stimulates more androgens from the theca lutein cells, and due to which there are signs of hyperandrogenism, acne, alopecia, and hirsutism. And there are signs of hyperandrogenism, this mentioned already, and signs of insulin resistance leading to hyperinsulinemia. And most important causes of, as mentioned, subfertility, weight disorder, and leading to abnormalities, metabolic abnormalities, dyslipidemias, and cardiovascular, and due to unopposed estrogen leads to hyperandrogenism. The investigations are basal 2 to 5 days, LH-FSH, prolactin, and testosterone. Signs of hyperandrogenism, and with this they needed SHBG and DHEAS, dihydroepiandrosterone sulfate, DHEAS, and androstenedione, and testosterone. And they, as told, there is a central obesity, so BMI greater than 30. So all these criteria, most important is hyperandrogenism and insulin resistant hyperandrogenism, leading to increased production of androgens from LH through ovarian theca lutein cells. And there are the long-term consequences of polycystic ovarian disorders are that it leads to metabolic abnormalities, especially dyslipidemias, leading to cardiovascular diseases, though this has not been proven yet. But it is a fact that increase in weight, more increase in dyslipidemic disorders, and obesity central obesity. These are all criteria for having hypertension and diabetes and unopposed estrogen, leading to endometrial hyperplasia. Most women who conceives with this gestational diabetes have an increased chance of having this diabetes in their later life. And also, since there is hyperandrogenism and there is unopposed estrogen leading to endometrial hyperplasia, leading to endometrial cancers. So, leading to dyslipidemia, central obesity, leading to cardiovascular disorder, hypertension and diabetes, and ischemic heart diseases. And second is the having having increased chance of diabetes and gestational diabetes, and then these gestational diabetes in pregnancy can later have increased chance of diabetes mellitus. And unopposed estrogen leads to endometrial hyperplasia, lead to endometrial cancer. Now the management of this endocrine disorder, which is characterized by hyperandrogenism and high insulin resistance and central obesity, and signs of hyperandrogenism, hirsutism, acne, alopecia. So the most important thing is the lifestyle modification, healthy lifestyle, reducing the weight through exercises and through lifestyle modification, walk, and also can lead to this. Not only because the most important thing, as I have told you about the PCOS, is the anovulatory subfertility, anovulation, absent ovulation. So with this reduction in weight loss, even in 5% weight loss reduction, it leads to significant improvement of these symptoms of anovulation and absent ovulation, and lead to regularity in cycles, which are basically irregular or absent and totally anovulatory cycle, leading to infertility, subfertility. Then we have some drugs as well. Through lifestyle, we have done with walk and exercise, reducing the weight, reducing the BMI, leading to ovulation, leading to reduction in the ovulatory disorders, leading to subfertility, also improving fertility, subfertility. And then through how can we help this hyperandrogenism leading to alopecia, hirsutism, and hair growth and acne. These can be helped through a lot of cosmetic approaches, depilatory, plucking, shaving, waxing, all these cosmetic measures. And then we have got the drugs as well, anti-androgens, ephornithine, spironolactone, aldactone, spironolactone, and flutamide, finasteride, flutamide, and GnRH agonist, finasteride, flutamide, and spironolactone, aldactone. These are all which reduces the hyperandrogen levels, decreasing the acne, hirsutism, and improve the growth of the hair, alopecia also. Then we can have COCP, which regulates, they increase the level of they reduce the androgen by increasing the level of SHBG, and the cyproton acetate combination of ethylene plus ethylene and cyprindione provide us withdrawal bleed. in an evolution. And then all we have mentioned, lifestyle subfertility can be improved by restoration of ovulation, and the absent ovulation is restored. Regular cycles are restored by reducing the weight, laparoscopic diathermic drilling, ovarian drilling, and then also can help with the leading to ovulation induction with the GnRH analog and with metformin and with clomiphene citrate. So the drugs which are used for ovulation induction, as mentioned, is metformin. Metformin is a very important drug, though it is not licensed in United Kingdom, but is FDA licensed drug and is used for restoring the regular ovulatory cycle and improving the fertility, and it can also be combined with clomiphene for ovulation induction, as mostly I have told you that polycystic ovarian syndrome is an ovulatory leading to an ovulatory subfertility. So, but it does not help in hyperandrogenism, hirsutism, acne, alopecia, but definitely it helps in the restoring the regularity of the cycles and improving the fertility rates. As PCO is a very important disorder, it's having very distressing symptoms, so needs additional motivation and support, because it leads to distressing symptoms and what you can say low esteem, stress, anxiety, and depression also. So a multidisciplinary team is needed, and holistic approach and efforts are needed, and support in order to tackle such endocrine disorder with hyperandrogenism and insulin resistance. Thank you very much. Takeaway lesson is pray, praise, trust, love Allah. Always worship Allah, always, and follow the lifestyle of our Prophet Hazrat Muhammad sallallahu alaihi wasallam. Darood un par, our health and survival, and we must always Allahumma zikrak, shukrak, husn ibadatak, wa kufa billahi waliya, wa kufa billahi nasira, subhanallah wa bihamdihi, subhanallah al-azim. And we must not forget our glorious past. वो मुअज़्ज़ज़ थे, वो मुअज़्ज़ज़ थे सारी दुनिया में मुसलमान होकर, हम ख्वार हुए तारिक कुरान होकर, दहर में इसमें मोहम्मद सल्लल्लाहु अलैहि वसल्लम के उजाला कर दे। एंड दुनीम इनकी ठोकर से सहरा व दरिया, सिमट कर पहाड़ इनकी हैबत से रहे। दी अजाने कभी यूरोप के कलीसाओं में, कभी अफ्रीका के तपते हुए सहराओं में, और ऑलवेज आस्क फ्रॉम अल्लाह। हम तो माइल बकरम हैं, कोई साइल ही नहीं, राह किसे दिख रहा है, राहबर मंजिल ही नहीं। वमा अलैना इल्लल बलाग। थैंक यू वेरी मच. We'll come with another review.